Welcome to Module 12 of our HIV/AIDS First Aid course. In this section, we're going to focus on stigma, bias, and cultural humility within behavioral healthcare and addiction counseling settings. And this is an extremely important topic because even when counselors have accurate medical information about HIV, the stigma and the unconscious bias can still affect our interactions with clients. And stigma is not obvious all the time or intentional all the time, but it can appear through your tone of voice or your assumptions or your body language or discomfort around the client or with talking about it or avoiding the client or talking about it, or maybe even just subtle differences in how that client is being treated. And clients living with HIV or engaging in high-risk behaviors are often sensitive, highly sensitive to these reactions because they've already experienced judgment and rejection and discrimination repeatedly throughout their lives. So as counselors, it's important to understand the emotional safety and how that affects treatment engagement. Because if a client feels judged, they're less likely to disclose anything honestly to you. They're less likely to even come seek health care or ask questions or remain in treatment or trust us. So this module is going to help us focus on how stigma develops, the effects of bias in counseling relationships, and the importance of cultural humility, and some practical ways that we can create safer and more respectful treatment environments. This is not about perfection or being politically correct. It's just about being professional and having some self-awareness and improving our client care. So stigma refers to negative attitudes, stereotypes, and judgments that are directed towards people or groups based on certain characteristics and experiences. So HIV stigma may involve beliefs that people living with HIV are irresponsible, they're dangerous, they're morally flawed, or they somehow deserve the illness. And stigma may also affect people associated with substance use or sex work, or maybe they're homeless or incarcerated or any of the marginalized communities. And these judgments often develop because people are fearful or misinformation, cultural beliefs, or historical social attitudes towards them. And the stigma is external, meaning it's discrimination from outside sources, or it can be internal, like individuals begin believing negative messages about themselves. And that internalized stigma can then affect their self-esteem and their mental health and their healthcare engagement and relationships and recovery. And so clinicians should recognize that stigma is not just simply an emotional issue, it directly affects public health and treatment outcomes. People are less likely to seek testing or to disclose their concerns or access healthcare when they fear that they could be judged or rejected. Bias doesn't always appear in obvious or intentionally harmful ways. Sometimes bias shows up subtly through assumptions or discomfort, body language, tone of voice, differences in how we're responding to different clients. So, for example, maybe the counselor may unconsciously assume that certain clients are what we would consider high risk, or that certain groups are more responsible for HIV, or that certain behaviors reflect moral weakness rather than complex social and psychological factors. But bias can appear through language sometimes, and there's some terms that shame or dehumanize clients, and that may increase stigma and reduce emotional safety. So we need to pay attention to the emotional reactions. Feelings like disgust or fear or frustration or any type of moral judgment that can unintentionally affect interactions when we as clinicians believe that we are behaving professionally. And the clients often notice the little subtle changes in behavior very quickly. So the goal is not to shame clinicians for having reactions or having biases. All humans are going to develop assumptions based on experiences and culture. But the goal is more so awareness and professional responsibility. The more information that you have, the more professional that you can be. Stigma can have really significant emotional and behavioral consequences for our clients because they're going to avoid HIV testing. They're going to delay their treatment. They're going to hide their symptoms. They're going to avoid healthcare altogether or refuse to even discuss their concerns honestly. And some people isolate themselves socially because they fear they're going to be rejected or discriminated against. They're going to experience depression, anxiety, shame, hopelessness, and chronic stress that's related to that stigma. And the internalized stigma can also affect their recovery and their treatment engagement. Clients who believe that they're damaged or they're unworthy may struggle with motivation, or they may struggle with self-care or their trust in supportive relationships. And so we have to recognize that stigma often compounds the existing trauma and mental health concerns. And it's really important in addiction treatment settings where a lot of clients are already experiencing shame that are related to the substance use histories. So reducing that stigma is going to improve both the emotional safety and the healthcare outcomes. A lot of our clients experience multiple forms of stigma at the same time, and we call this intersectionality. So, for example, a client may simultaneously experience stigma that's related to their HIV status and addiction and their race, or maybe poverty or homelessness or their sexual orientation, or maybe it's also mental illness or their criminal justice involvement. All of those carry stigma. And these overlapping experiences can significantly affect their emotional well-being and their healthcare access. If they have repeatedly experienced discrimination, they're going to develop a little bit of distrust towards systems and providers and authority figures. I cannot tell you how many times clients have come to me that are mandated to do treatment and they think that I work for the probation office. So they're already coming in judgmental about this, and as they should. So we need to avoid oversimplifying clients' experiences or assuming that one issue exists in isolation from the others when they don't. Cultural humility is recognizing that each client's experience is shaped by multiple personal and social and cultural factors. So professional counseling is going to require us to be curious and open rather than just having our assumptions. And cultural humility is slightly different from the idea of cultural competence. Cultural competence sometimes suggests that professionals can feel, or they can fully master knowledge about different groups or cultures. But cultural humility recognizes that learning is always ongoing. So it involves being open and curious and being willing to self-reflect and being willing to recognize that there are limitations in our own understanding. No counselor can fully know each client's lived experience. So they should remain willing to listen and ask respectful questions and examine their own personal assumptions and continue learning over time. And the cultural humility is going to be about recognizing power dynamics within these helping relationships, because our clients are often entering counseling systems from vulnerable positions, particularly when they're dealing with addiction or legal involvement or trauma or health concerns. So respectful collaboration is going to improve trust and the treatment engagement. Language can either reduce the stigma or it can reinforce it. So person-first language is going to help emphasize that individuals are more than their diagnosis. They're more than their behavior. They're more than their health conditions. So an example might be like a person living with HIV, instead of saying, identifying or defining someone solely by their diagnosis. So like a phrase like a person with a substance use disorder as opposed to an addict. Saying a person with a substance use disorder is generally more respectful than a label that reduces the person to their addiction. So we should avoid dramatic or that fear-based language when we discuss HIV. The goal here is factual, respectful communication. We don't want to create panic. We don't want to create shame. Simple communication choices can significantly affect how emotionally safe a client feels during a conversation. So your professional tone is going to matter just as much as the factual accuracy. And a lot of clients affected by HIV stigma or substance use stigma also have significant trauma histories. And trauma-informed counseling is going to recognize that clients may have experienced abuse or rejection or discrimination. They've maybe witnessed or been the victim of violence, or they've had some sort of medical trauma or systemic mistreatment. And so we should avoid approaches that increase the shame or humiliation, or that can really just emotionally overwhelm the client, because trauma-informed care is going to emphasize emotional safety and trustworthiness and empowerment. But we're also working on collaboration and respect with the client. And when the client feels safe, they're more likely to engage honestly and remain in treatment and access those healthcare resources. So the trauma-informed care is not about avoiding the difficult conversations. It's about having those conversations in a respectful and an emotionally responsible way. So professional growth is going to require self-reflection. We should regularly examine our personal assumptions, our emotional reactions, and our own discomfort and our own emotional biases. So we need to ask ourselves, like, do I react differently to certain clients? What kind of assumptions do I automatically make? How do my experiences shape my responses? What kind of topics make me uncomfortable? Being aware of these does not mean that we're bad people. It just means that we're humans and we're committed to ethical growth and professional responsibility. Supervision, consultation, continuing education, and honest self-reflection all support better client care. So an inclusive counseling environment can be intentionally created. And the clients notice whether the treatment setting feels respectful or emotionally safe and welcoming, or does it feel judgmental? And we can create those safer environments by using respectful language and avoiding assumptions. We want to remain emotionally steady and respond calmly to sensitive disclosures. We also want to normalize discussions about testing and prevention and sexual health and substance use and healthcare. That's going to help reduce the shame and the stigma, because the goal is not to eliminate all discomfort. Difficult conversations are a part of counseling work. The goal is to ensure that our clients feel respected while navigating those conversations. So as we close this module, I just want you to remember that stigma and bias can significantly affect treatment engagement and healthcare access, the client's emotional well-being, and their recovery outcomes. Clinicians have a really important responsibility to remain self-aware and culturally humble and professionally respectful in all client interactions. So reducing stigma is not just simply about the language, it's about creating emotionally safe environments where the client can feel seen, they can feel respected, and they feel supported. So in the next module, we're going to transition into the first aid portion of the course, beginning with universal precautions, bloodborne pathogens, and maintaining safety in behavioral health settings. So when you're ready, proceed to module 13.